Non-surgical conservative management is the standard of care for asymptomatic abdominal aortic aneurysms that fall below the threshold for elective repair. Intervention is typically deferred until the risk of rupture, which is remarkably low for small abdominal aortic aneurysms, outweighs the procedural risks of endovascular aneurysm repair or EVAR or open surgery. Elective repair is generally indicated when the abdominal aortic aneurysm reaches 5.5 cm in men, 5.0 cm in women, or a rapid expansion rate of 0.5 cm or more within 6 months. Imaging surveillance relies primarily on ultrasound to track the maximum anteroposterior diameter. Computed tomography angiography, CT angiography, is generally reserved for treatment planning once the diameter threshold has been met or if rupture is suspected. The 2024 Society for Vascular Surgery guidelines recommend the following gender-specific screening intervals. Aortic diameter 25 to 29 in men every 5 years, in women every 5 years, 30 to 39 every 3 years in both men and women, 40 to 44 annually in both men and women, 45 to 49 annually in men, every 6 months in women, 50 to 54 every 6 months in men, more than 55 mm is elective repair. For women, 50 to 54 range is repair indicated because 50 mm or more is elective repair for women. ACC/AHA 2022 guidelines offer closely aligned intervals, typically recommending 3-year intervals for 3.0 to 3.9 cm, annual imaging for 4 to 4.9 cm, and 6-month imaging for 5 to 5.4 cm. Pharmacotherapy and lifestyle modifications focus on reducing overall cardiovascular morbidity, though no specific medication has been definitively proven to halt AAA expansion. Smoking cessation. This is the most critical modifiable risk factor. Continued smoking is directly correlated with accelerated expansion rates and a significantly higher risk of rupture. Cardiovascular risk reduction. Standard secondary prevention protocols apply, requiring strict blood pressure control, high-intensity statin therapy, and antiplatelet therapy. Physical activity. Routine exercise do not need to be restricted in patients with small asymptomatic abdominal aortic aneurysm. Fluoroquinolones. While the FDA previously issued warnings regarding fluoroquinolone use in patients with aortic disease, the 2024 ESVS guidelines clarify that a small abdominal aortic aneurysm is not a strict contraindication if these antibiotics are otherwise clinically necessary.